So now let's see the mechanism of action of the different pre-medication drugs. So coming to the Acepromazine, it is a phenothiazine derivative, and if you see the mechanism of action, it antagonizes the alpha-1 receptors and also the dopaminergic receptors, those are D2. So the alpha-1 receptors mainly located in the blood vessels, the arterioles. So the main function of the alpha-1 receptors is to constrict the blood vessel. I mean, the arteriole will be constricted. Whenever the arteriole is constricted, obviously the blood will be pulled before the front portion of the arteriole, and it causes the hypertension. Okay, so but here what is happening with the Acepromazine is it is antagonizing that effect. So that will lead to the dilatation of the arteriole. So if the arteriole is dilated, obviously it will lead to the hypotension. So it can directly cause the hypotension in the patients if we give higher doses. So apart from this function, it also has the antiemetic property by inhibiting the D2 receptors. So the peculiar thing with the Acepromazine is it takes almost 30 minutes to show its effect, and the long duration of the Acepromazine is one of the advantages to use this as the pre-medications. Okay, since it is metabolized in the liver, we should not use in case of the liver diseases. And apart from this, the other contraindications include the hypovolemia and hypotension, and especially the dogs which are fractious, which are aggressive. We should not use the Acepromazine in case of the fractious dogs. So this is all about the Acepromazine. And one more disadvantage with the Acepromazine is it doesn't have any reversing agent. Okay. So now let us see the Dexmedetomidine. The Dexmedetomidine is an alpha-2 agonist. So the alpha-2 receptors are present in the presynaptic neurons. So if we see the synapses means the place where the two neurons are connected, and this area will be released. At this area, the neurotransmitters will be released. In adrenergic nervous system, the main neurotransmitter is norepinephrine. Okay, so whenever these alpha-2 receptors located in the presynaptic neuron, if these receptors are activated, then the norepinephrine release will be inhibited. So that's why these alpha-2 receptors are called presynaptic inhibitory receptors. Even though it is a alpha-2 agonist, but the action will mimic the parasympathetic action. Even though it is an adrenergic agonist, but the action will be the opposite of adrenergic nervous system. So usually adrenergic nervous system increases the heart rate and increases the norepinephrine action, but here the norepinephrine release is decreased since the alpha-2 is located presynaptically. Okay, this is a control mechanism for the adrenergic nervous system. So the presynaptic alpha-2 receptors, whenever they are activated with the Dexmedetomidine, it will reduce the sympathetic nervous system tone. So that will reduce the heart rate, and subsequently it reduces the cardiac output. And apart from this, it also inhibits the nociceptive neurons. So that is the main reason why the Dexmedetomidine has the analgesic effect along with the sedation. Okay, so coming to the effects of the side effects of the Dexmedetomidine, it reduces the cardiac output around 20 to 40% because of this effect. And whenever we give the Dexmedetomidine, the initial effect will be increasing in the peripheral vascular resistance because it constricts the arterioles. So that increases the peripheral vascular resistance, that subsequently leads to the hypertension. So whenever the hypertension is there in the body, it usually responds with a bradycardia. That's why it's called as reflex bradycardia in order to cope up this hypertension. Okay, so this is the first, whenever we give the Dexmedetomidine, this is the initial effect we will see. But this bradycardia will be maintained because of this action, because there is no sympathetic tone at all. There is no norepinephrine release, there is no increase in the heart rate. So the bradycardia will be maintained. So the main disadvantage of the dexmedetomidine is in creating this bradycardia. Okay, but it is better than the xylazine. The xylazine can cause the second degree AV black, and if it is not widely used right now in comparison to the dexmedetomidine, which is a highly safer in comparison to the xylazine. So the main purpose of using dexmedetomidine is because of its action of sedation and analgesia, and it can reduce the use of it can reduce the induction dose and also reduce the MAC value of inhalant anesthesia. So these are the main advantages of the dexmedetomidine, and the main disadvantages is it can be used only in ASA 1 and 2 categories of patients. Okay. So coming to the midazolam and diazepam, they comes under the benzodiazepine group, and they stimulate the GABA. So the GABA action is increased. So the GABA is a neuroinhibitory transmitter. So it inhibits the central nervous system, and these two drugs will promote that inhibitory action further. So it will leads to the varying degrees of sedation, hypotension, and this can reduce anxiety in the patients. And the midazolam and diazepam, we use these two drugs in convulsions, especially to control the convulsions. So that's why it is act as anticonvulsant. So it can also help in skeletal muscle relaxation. Okay, the main purpose of the diazepam is for the sedation and skeletal muscle relaxation, but it doesn't have the analgesic property, whereas the dexmedetomidine has analgesic property. Acepromazine doesn't have any analgesic property; it only causes the sedation. Okay, so this is about the midazolam and diazepam. So what is the main advantage of the benzodiazepines? Here we can see we can use in young and geriatric animals. We can use them without doubting about cardiovascular depression, since it is having very mild cardiodepressant properties. So we can use them in young and geriatric and also the critically ill patients. Okay. So one interesting thing I will tell you about the diazepam and midazolam, that is, so that diazepam cannot be given. I mean, it is not like cannot. So you cannot assess how much amount of diazepam is going to absorb if you give the in the intramuscular route, because it contains the propylene glycol. So that propylene glycol, because of the presence of propylene glycol, you cannot estimate how much amount of diazepam is going to absorb from the muscle. Okay, but that is not the scenario with the midazolam. Okay, so if you give the midazolam IM route, you can estimate how much amount of midazolam is going to absorb. Okay, so one more interesting thing about the diazepam is you should not give this drug quickly whenever you want to give in the IV route, because it can cause venous thrombus. Okay, and it also contains, I already mentioned that it contains the propylene glycol, which is a cardiopulmonary depressant. So that can cause a cardiac suppression and pulmonary suppression, and we should not use the plastic syringes for the storage of the diazepam, since it cannot absorb on the walls of the syringe, and you will be left with the propylene glycol. If you administer quickly, that can lead to the severe hypotension and bradycardia. So keep this thing in your mind. So coming to the anticholinergics, so I mentioned that the atropine and the glycopyrrolate are needed whenever you are giving vagotonic drugs such as propofol, opioids, and acepromazine. Okay, so in those conditions you will be using the anticholinergic drugs. So even though it increases the heart rate by inhibiting the acetylcholine receptors, it doesn't have any impact on acetylcholine release, but it has the effect on acetylcholine receptors. It will go and bind to the receptors, and the acetylcholine will not show its effect. So the heart rate will be increased. Since the parasympathetic nervous system decreases the heart rate, so any inhibitory action on the parasympathetic nervous system will increase the heart rate. So the one interesting thing about the anticholinergic drugs is whenever we give them in the IV route, they can cause second degree AV block by the vagotonic effect initially. So and also you should keep one thing in your mind, that when you give the atropine very minimal dose, that is around 0.003 mg per kg, that very minimal dose can increase the vagotonic effect. Okay, so it decreases the heart rate. It should have increased the heart rate, but because of this lower dose and its vagotonic effect, it will reduce the heart rate initially. Okay, that thing you can take care. So you should not give the atropine with the minimal dose. You should give appropriate dose. Then only it will increase the heart rate. Okay, and the main difference between atropine and glycopyrrolate is the glycopyrrolate cannot cause much tachycardia, just like the atropine. Okay, and the atropine can cause the blood-brain barrier, but the glycopyrrolate cannot. So this is about the pre-medication of the anesthesia.